Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling jaundice. Specifically, I'm going to talk about newborns, what's going on when they turn a little yellow, and when it is a big problem. As always, let's kick things off with our practice question. A nurse is assessing a 2-day-old term newborn who is exclusively breastfeeding, which finding requires immediate follow-up by the nurse. We have a yellow discoloration of the face and upper chest with a bilirubin level of 10. B, a total serum bilirubin of 18, poor feeding, and lethargy. C, yellow CD stools and 6 wet diapers in the last 24 hours. Or D, mild jaundice noted on day 4 in a newborn who is otherwise vigorous and feeding well. Okay, so think that through, tuck away what you think the right answer might be, and let's talk about jaundice, which to understand jaundice, you have to understand what bilirubin is and where it even comes from. The story starts back, believe it or not, in our red blood cells. In adults, red blood cells live about 120 days, but in newborns, their lifespan can be shorter, down to about 90 days or so. And when red blood cells get old, the body breaks them down. Mostly that happens in the spleen and liver. Now, as these cells get broken down, inside of them is hemoglobin. We know hemoglobin, I always compare to our Uber driver that carries our oxygen around and delivers it. Well, when we break hemoglobin down, it has 2 parts, heme and globin. Okay, hemoglobin, pretty easy. Globin is just a protein. It's recycled as amino acid, but the heme gets converted into bivalrudin and then unconjugated bilirubin. Okay, so that was a lot of steps in that chain. To keep it simple, red blood cells, they don't live forever. We break them down and we get bilirubin, specifically unconjugated bilirubin. And that's important because when it's unconjugated, it is fat soluble and it is toxic at high levels. It cannot just freely be floating around in the blood. So it grabs a ride on albumin in the bloodstream and it heads over to the liver. All right, basically picture that unconjugated bilirubin as like sticky yellow trash, and it gets dangerous as it piles up. Albumin is like the garbage truck that will pick it up and carry it safely to the liver. So red blood cell breaks down unconjugated bilirubin, that heads over to the liver, and in the liver, hepatocytes, our liver cells, take our unconjugated bilirubin and conjugate it. Remember, the liver's a factory that's always processing and metabolizing. So by conjugating that bilirubin, it turns it into conjugated bilirubin, which is now water soluble instead of fat soluble. It's less toxic and it can be safely dumped into bile and then the intestines. Once it is in the gut, we can then actually get rid of that, okay? There are 2 different ways. Some of that conjugated bilirubin turns into urobilinogen, which gets resorbed and excreted in the urine. That makes the urine yellow. But most will be converted into stercobilin, which goes into the stool, and that's what makes the stool brown. So if bilirubin doesn't get where it needs to go, stool and urine color can both change. But overall takeaway for you guys, red blood cells break down, we get unconjugated bilirubin. That unconjugated bilirubin goes to the liver, it conjugates it, and then the conjugated bilirubin can be excreted from the body in our urine and stool. Now, newborns are kind of dramatic about bilirubin, and there's 3 big reasons why we see increased bilirubin leading to jaundice in newborns. Numero uno, the newborn has high red blood cell turnover. They're born with a lot of fetal red blood cells and a higher hematocrit, okay? H&H, normal to be high in newborns. Right after birth, a ton of those fetal red blood cells get broken down, which means we're making extra bilirubin. Second big reason, newborns have immature livers. Those tiny little baby livers, they just do not conjugate our bilirubin efficiently yet. It's like we hired a brand new intern and we're expecting them to handle 3 full-time jobs. They are trying, but they're not fast enough yet, okay? So, we're making a lot of bilirubin and the liver's not great at conjugating it yet. Third reason we often see jaundice in newborns is that their circulation is just a little bit different. They have more enterohepatic circulation, meaning unconjugated bilirubin can actually get resorbed from the intestines and back into the liver because they've got extra blood, enterohepatic, stomach, liver, and that adds to the overall workload. So, higher workload because of the blood flow and they're making more bilirubin, and the liver is just not good at its job yet. So it can't conjugate efficiently. All of this means that bilirubin levels in newborns can go up. And we've spent this whole episode talking about bilirubin so far, but the title of the episode is actually Jaundice. When bilirubin goes up, jaundice is clinically what we see. It shows up as yellow skin and yellow sclera, the whites of the eyes, because that yellow trash, that unconjugated bilirubin, is being deposited into the tissues. We might see dark urine. We might see pale or clay colored stools because that bilirubin's getting deposited in our tissues instead of getting into the intestines and being recycled like we want it to be. So, why do we care? What does it matter if the baby gets a little yellow? Well, the dangerous part is with that unconjugated bilirubin. Remember, it is fat soluble, so it can cross cell membranes. And at high levels, that includes going across the blood brain barrier. When that happens, it can deposit in brain areas like the basal ganglia and the brainstem. All right, basically a bunch of yellow trash. It's getting stuck. We get a lot of it. It's got nowhere else to go. It's going to go in the brain. And what does that cause? The worst complication called kernicterus. This is also called bilirubin-induced neurologic dysfunction. And that pretty much tells you what's going on. We got too much bilirubin and it causes neuro problems. These can be things like vision trouble, motor problems. It can cause cerebral palsy. It is an emergency and it is always preventable. Okay. So, with that being said, let's walk us through a scenario so we can talk about how this presents and what we do about it. I have seen a lot of jaundice babies. I've seen a lot of babies that are totally fine, and then ones that they were not totally fine. It really went past the point of normal. So, I'll tell the normal story first. I think that'll be the best place to start. So, working in Mother Baby, that was actually the first place I started as a new grad. Started in Mother Baby. I did not want to start in Mother Baby, but that was where my job started me. So I was on the postpartum side, and we had clients like I'd say about 2 hours after delivery, and then they stayed for 2 to 3 days, depending on the type of birth. So this was like a 2-day-old baby. I was on night shift, and they were going to be discharged the next morning. Mom called me in, again, night shift. This was probably like 2 o'clock in the morning because she thought the baby looked a little yellow. Now, when I had done my like 7 p.m. checks, assessments, tucked everybody in for the night, the baby had been looking fine. I didn't really notice anything. And again, this was a 2-day-old born at term baby. That's important. Now, the baby was exclusively breastfeeding and had lost about 7% of birth weight. Now, if you remember, within that 10% is the acceptable range, but it's close enough. We're going to pay attention, okay? Asking mom about feeding, she's like, it's okay. She really didn't think that there were any problems. But when I asked more questions and watched the baby latch, I could see the baby, sucked a little bit and then fell asleep really quickly and was not getting a good full feed. Okay. So we have a baby. They've lost some weight since birth. That's normal. They're within range. I know they're not feeding great. Mom thinks they look a little bit yellow. Okay. So we go in, we assess the baby, turn on all the lights. If you have a baby that you think is jaundiced, you got to unwrap them and turn on all the lights, okay? Sorry, I know it's 2 a.m. That's less than ideal, but we need to really be able to see the color of the skin and the mucous membranes, including the sclera of the eye. And on assessment, mom was definitely right. The face and even a little chest and upper abdomen was yellow tinted, okay? Not dramatically bright neon yellow, but there was an undertone of yellow there. Baby's a little sleepy, but we could wake him up. Vitals were stable. And looking at the past 24 hours, he had had 3 wet diapers and 2 stools. Not terrible, but not amazing. I would expect him to be having more if his feeding really was adequate. So what's going on here? Okay. There are a lot of fetal red blood cells breaking down, which means a lot of unconjugated bilirubin being produced. The liver is still immature, so conjugation is slow. Feeding's not great, so there's less stooling going on, and less stooling means more bilirubin is being resorbed from the gut through that enterohepatic circulation. We send it right back to the liver. So, long story short, even if you don't remember all that mumbo jumbo, the bilirubin is building up and it is turning the baby yellow, hence jaundice. Okay, so what do? We draw some labs. We're going to see how high is that bilirubin actually coming back. We have a tool that calculates for us hours of life and how high the bilirubin is to let us know if it is normal. I do not recommend memorizing these lab values. It is not that important. For this kiddo, I do remember the bilirubin coming back around about 16. Again, he was 2 days, so let's say 48 hours of life. And that did not put him in the panic zone. It put him kind of in the middle zone. This chart comes back and it tells you low risk, intermediate risk, high risk. And if it's high risk, then we need to, move and groove. We need to do some things. If it's low or intermediate risk, what we need to do is feed that baby, get them really latching, supplement with formula if that is acceptable to the parents, and get them stooling so that we are actually getting that unconjugated bilirubin out of the body. And that's your intervention when it's not an emergency yet. So for this baby, it's not an emergency. Priority number 1, frequent effective feeding. Have a lactation consultant work on that latch, get more volume in so that we get more stool coming out. More stool means more bilirubin exiting the body, okay? And then you're monitoring and trending that bilirubin. You want to recheck it later that day and see if it's going up or down. You also want to know, how is the baby responding? Are they lethargic? Are they sleepy? They're not waking to eat? That combination would be concerning. Or, is that bilirubin kind of staying steady, coming down, but they're awake, they're vigorous, they're feeding well? For this baby, this was a pretty normal case. Lactation consultant came in. We got good feeds going on. He had more going in, put more out, and we got that bilirubin level coming down. That's all we needed to do there, okay? Pretty cut and dry. Let's kind of rewind and see if it had gone another way. If we had rechecked that baby's bilirubin and it was up to 20 and they were lethargic and they were still not eating well, that combination of a rising bili and lethargy would really increase our concern. So the next step in our intervention is something called phototherapy. This is one of my favorite things to talk about. I call it the baby tanning bed because I think it is absolutely adorable. It is basically a special blue light that's going to help us out while that liver is not doing too much. It changes the unconjugated bilirubin in the skin into more water-soluble isomers, which can then be excreted without needing conjugation by the liver. In other words, that light is temporarily doing some of the liver's work for the baby. Now, there are some nursing must-knows when it comes to phototherapy, okay? The principle is simple. They have too much bilirubin. The light helps us break down bilirubin, and then they need to excrete it out of the body. Okay, perfect. Now, what we need to do as the nurse includes keeping the baby only in a diaper and sunglasses. Okay, they're not actually called sunglasses, but they really are these like baby little sunglasses, this little eye shields, because the light can hurt their eye and their private area. So diaper on, sunglasses on. This is why they're in the baby tanning bed. Additionally, need to keep the rest of them naked. All right, just the diaper and just sunglasses, because remember, that light is working by going into the skin and converting that unconjugated bilirubin. So if they're swaddled up, that light's not touching their skin, it's not doing their job. They're naked except for a diaper and sunglasses. Now, because they're naked, they are at higher risk for temperature instabilities. They're under a light, they can become overheated, they're unbundled, they can become cold. So we keep an eye on their temperature very closely. We also keep very close measurements on their intake and output. They're going to be on strict I's and O's because the more they eat, the more they can stool. The more they can stool, the more bilirubin can be excreted from their body. So if they're not eating well, the light's breaking things down, but nothing's getting out of their body. So strict I's and O's. And then, of course, continuing to monitor that bilirubin level. We're going to do that at least once a day. I usually had orders to do it Q12 hours, so once a shift. So we would see if that phototherapy was doing the trick. Now, we have multiple levels of phototherapy. It can be single, double, triple, basically how strong the lights are. So if it's still not improving, we can kind of increase how strong we're going with the phototherapy. And then over time, that phototherapy should be doing its thing, breaking the bilirubin down. The baby wakes more easily, feeds better. With more in, we get more out. We get that bilirubin out, and they are on the good path to recovery. So those are your big things to keep an eye on with a newborn with jaundice. Yes, that bilirubin is going up. That's causing the yellowing. That's the clinical picture that we see that we keep an eye on. But what we're really worried about is the brain. Too much of that bilirubin, think of it as that yellow trash sticking around. It's fat soluble. It can go into the brain and cause kernicterus. So if they are sleepy, difficult to wake, having neuro changes, that's when we get really, really scared. And at a basic level, what we do is feed them so that they can get that bilirubin out. If that's not enough, we will add on that photo. And remember, with phototherapy, our nursing interventions are to make sure they are naked except for a diaper and sunglasses, to keep a close eye on their I's and O's and their temperature. That's kind of phototherapy in a nutshell for you. But with all that being said, now you've kind of walked through a case. You've seen how a baby responds to photo and what we do as a nurse. Let's circle back to our practice question and see now if you can get to that right answer and understand why. A nurse is assessing a 2-day-old term newborn who is exclusively breastfeeding, which finding requires immediate follow-up by the nurse. We have A, yellow discoloration of the face and upper chest with a bilirubin of 10. B, total serum bilirubin of 18, poor feeding, and lethargy. C, yellow CD stools and 6 wet diapers in the last 24 hours. Or D, mild jaundice noted on day 4 in a newborn who is otherwise vigorous and feeding well. What is the newborn that requires immediate follow-up? A, B, C, or D? Jot it down, say it out loud. I think you've all got it. B. That infant with a high bilirubin, poor feeding, but really what worries me is lethargy. Lethargy is your red flag. That's what should have jumped out and made you choose B. Neurologic changes like lethargy signal a risk for that bilirubin going up into the brain and causing chaos, potentially kernicterus. We urgently need to intervene, probably phototherapy. Our other options, well, maybe not perfect, are not emergencies. A yellowish of the face and upper chest, yellow CD stools, and mild jaundice on day 4 can all be normal or physiologic. They don't signal anything emergent, which is really our big takeaway. Jaundice isn't just a yellow baby. It's all about that bilirubin. Red blood cells break down, and that leaves us with our unconjugated bilirubin, which goes to the liver so it can be conjugated and then safely excreted into the stool. Newborns are really vulnerable because they make more bilirubin and their livers are just not good at getting rid of it. So we as the nurse need to recognize what's normal versus when does it cross that threshold of being dangerous, lethargy, poor feeding, difficult to wake. And then we need to support that feeding to get more in so that the bilirubin can come out. And if you start to see neuro changes, act quickly because it could be a sign of kernicterus. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.